Medurstand, Understanding Medicine.
I'm Professor Azizur Rahman, and we are discussing various ECG abnormalities. And uh, in the last lecture, we discussed pathophysiology and anatomy, and today we are going to take up anteroseptal infarction. This is the curriculum. We have discussed these three topics already, and acute coronary syndrome, anteroseptal STEMI, we are going to discuss today. Very briefly, I will quickly go through those concepts which were discussed in the last presentation, last video. You could consider it as revision, or those who land up here directly, for them it would be useful. In this module, we are going to take up anteroseptal and anterolateral STEMI, which constitute the whole anterior wall. So we will show you different slides showing you anteroseptal and anterolateral or anterior wall infarction. Rest of the infarctions will be covered in remaining videos. Now this is the revision of anatomy. This is the left main and this is the left anterior descending artery, which is likely to be involved in anteroseptal STEMI. This is the lead representation of anterior wall, and these are the leads which are likely to show changes due to anteroseptal STEMI, V1 to V6, because they just pass over the heart and they look at heart from very close distance. They show changes in very typical form. And this is also the same thing which we discussed. If this is infarcted part, say anterior wall, the anterior lead would show changes, ST segment elevation, followed by T wave inversion, followed by Q wave, depending upon when patient presents. If patient presents early, there will be ST segment elevation alone. If patient presents little late, after a few hours, there would be additional T wave inversion. If patient presents after many hours, then there would be Q wave also present. So depending upon the time, you would see the changes. And in opposite lead, you might see ST depression. Now this is the something which I showed you, and V1, V2, V3, V4, V5, V6, these are the leads which represent the anterior surface of the heart, and anteroseptal infarction would be shown in these two and also maybe adjoining leads depending upon the extent of infarction. Now this is pathogenesis we discussed, and since we are going to talk about STEMI, we are going to cover this part. It's full thickness, a big clot causing full thickness infarction, causing ST segment elevation infarction. And in this video, we will cover the anteroseptal region, most probably due to LAD disease. Now, this part was also discussed. Full thickness infarction would cause ST segment elevation in the corresponding leads and ST depression in the reciprocal leads. A non-full thickness infarction would cause ST depression. This we will discuss in a separate module. So this was the background, and now we are going to take up just 3 or 4 ECGs and going to observe them in detail. And this is the kind of exercise, and I think that will help you to understand and memorize how to make a diagnosis of anteroseptal myocardial infarction. This is again what we have discussed. ST segment, the hyperacute T wave followed by ST segment elevation with the reciprocal changes, followed by T wave inversion, and somewhere during the course patient develops Q waves, and Q waves remain forever mostly, but the rest of the ECG changes, ST segment elevation, T wave inversion, they become normal. Now, let's come to the exercise. This is a patient who has presented with severe central chest pain with diaphoresis. He is cold and clammy, and this is the ECG. Now, whenever you see an ECG, I think first maybe you can see this one, rhythm, This is a continuous recording of lamely 2. Lamely 2 or V2 are usually used for the analysis of rhythm because you can see a well-formed P waves in these two leads. So you can see P wave PQRS, PQRST, PQRST, and everything is nice here. Rhythm is very regular, rate is okay. Rate is normal and rhythm is regular. All right. So once you have ensured that, then you scan the ECG in a particular sequence, lead 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. Now, if you're experienced, then of course abnormality would immediately attract your attention. But if you're not, then you must go in the proper sequence so that you do not miss any abnormality. So what we are going to do is to look for changes of myocardial infarction in leads 1, 2, 3. I don't see much here. AVR, AVL, AVF. Again, I don't see any significant ST segment elevation, but things are different here. Look at this V1, V2, V3. This is the isoelectric line. This is the isoelectric line, and this is the ST segment. This is the isoelectric line, and this is the ST segment. Here, this is the isoelectric line. Isoelectric line is where the ST segment, the PR interval and TP interval lies. I'll just show you in just shortly. And then there is some changes in V4 also, but V5 looks normal, V6 normal. So this is the hint. This is the arrow shows the abnormality. In V1, V2, V3, there is marked ST segment elevation. And if we measure ST segment elevation, it is like average 10 millimeter. 1 or 2 millimeter ST segment elevation in proper perspective may be significant. Here it is 10 millimeter massive ST segment elevation. So we see ST segment elevation, and this ST segment elevation is seen in particular leads V1, V2, V3 and V4. What is common in these leads? They represent the anterior side, the anteroseptal and the anteroapical region. And that part is perhaps infarcted. And since it is ST segment elevation, it would be ST segment elevation type of myocardial infarction. So this is the diagnosis, Anteroseptal STEMI, and it is acute. Why we say acute? Because there is massive ST segment elevation. With time, ST segment starts settling down. And with time, T wave inversion also occurs. In this case, we do not see any T wave inversion. And with time, Q waves also develop. In this ECG complex, we do not see Q waves also. If you look at this complex, there is initial upward deflection here. Here again, so these are actually R waves. So any wave which follows an R wave cannot be Q wave. So these downward deflections are not Q waves. And the T wave inversion is also not there. So it has to be very, very acute phase. I don't see hyperacute T wave here, but I see ST segment elevation in massive level and seen in anteroseptal lead. So that leads to the diagnosis of anteroseptal STEMI, ST segment elevation type of myocardial infarction. Theoretically, we cannot say myocardial infarction unless we demonstrate that this patient has troponins elevated also, because these changes may be reversible. If changes reverse with intervention or spontaneously, then technically patient did not develop myocardial infarction, right? So myocardial infarction would be diagnosed when we have Q waves or when we have documented elevated troponins. So at this level, we would call it acute coronary syndrome. Very likely to go into infarction, but technically this is acute coronary syndrome of ST segment elevation type. So I hope this was easy. And how do we make a diagnosis? And these are the criteria listed. So criteria of infarction, we see ST segment elevation with convexity upward. As you see this one, convexity upward, and followed by T wave inversion. In this case, there isn't seen. I think maybe here you can suspect some T wave inversion, but no Q wave seen. Q wave is one of the criteria, but I have struck it here because I don't see Q waves here. And in which lead? In V1 to V4. And we are discussing the criteria of Anteroseptal STEMI. So this is how I made the diagnosis of Anteroseptal STEMI on this ECG. Now we are going to repeat the exercise in 2-3 different ECGs to make the concept better. Culprit artery. If you recall your knowledge of anatomy, which artery supplies anterior surface of the left ventricle? It is the left anterior descending artery. So from this distribution of changes, you can judge that left anterior descending artery is affected. Normally, you would expect this finding only from angiography, but from good clinical approach, you have made the diagnosis of arterial involvement in acute myocardial infarction. This is it. So this artery, LAD, this one is LAD, a branch of left coronary artery which descends like this, and this is the anterior wall of the left ventricle. So it is easy to understand now. Let's take up another example. This is another patient who has again presented with chest pain, but the duration was little more. Okay, now let's examine this ECG in the same fashion. First, see the rhythm lead. This is the continuous recording of limb lead 2. So no problem with rate, it's decent, and it is not tachycardia, it is not bradycardia, and there is no arrhythmia at all, no ectopics. All right. So now we scan all the leads, all the limb leads and pericardial leads in a particular sequence: lead 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. So what we are looking for is changes of acute myocardial infarction, and we are discussing STEMI. So we are basically looking for ST segment elevation, and we will see in which group of leads these changes are present. Limb lead 1, I don't see any problem. Limb lead 2, no problem. 3, no problem. AVR, AVL, AVF. Up till this, everything sounds very, very decent. But when we come to V1, you can see the complex is inverted and you can see ST segment elevation. There is definite ST segment elevation in V1, in V2, and in V3. Maybe a little bit of in V4 also. So there is ST segment elevation in V1 to V4. But unlike the previous ECG, in this case, there is very significant T wave inversion also. T wave inversion is seen here, T wave inversion is seen here, here, and also here. So in this case, we have two changes. We have ST segment elevation, which is not as much as we saw in the previous ECG, because as I said, ST segment changes, they start settling down, and then T wave inversion starts. And maybe you can also see some Q wave appearing. This is Q wave, and this type of complex is called QS complex. If you do not have R wave and just downward deflection with the rounded start, this is called QS complex. This is considered equivalent to Q wave. So what you see here is ST segment elevation and T wave inversion in V1 to V4. So anteroseptal STEMI of few hours, slightly longer duration than the previous because the T wave inversion is also there. Criteria V1 to V3, I think V4 also. There's ST segment elevation in V1, V2, V3, not in V4. In V4 we have T wave inversion but no ST segment elevation. T wave inversion V1 to V4, and Q waves in V1 to V3. This is QS complex, and this is the Q wave. So I think it is anteroseptal STEMI of several hours. And culprit artery, just like the previous ECG, it is left anterior descending artery. This is another patient. This is still another patient who again presented with chest pain. Rhythm lead is okay. And if we go through the other leads, limb lead 1, 2, 3, AVR, AVL, AVF. Remember, we are looking for ST segment elevation. These two leads, 2, 3, and AVF, they are predominantly inverted. They reflect some kind of fascicular block, which we'll discuss in a separate module. But these are not changes of infarction. Please note down that this is not actually a Q wave, because there is initial R wave. See, in the beginning of the QRS complex, you have this little very small tiny upward deflection, that is R wave. This is R wave. So these are not the QS complexes. These are not Q waves. This one is also not Q wave. So what change do we see is in the precordiales. V1, there is a little bit of ST segment elevation. Here again, somewhat ST segment elevation and very T-wave inversion, very significant Q wave here, very significant QS complex, ST segment elevation, T-wave inversion, and again here ST segment elevation, T-wave inversion, and QS complex. And in V5, you just have T-wave inversion, and V6, you also have T-wave inversion. So maybe this is infarction, which is even of more longer duration. So anteroseptal STEMI, we can call it infarction because now we have Q waves. This patient, I'm sure, would have positive troponins, but even if we do not have that report, based on the presence of Q waves, we can make a diagnosis of myocardial infarction, not just acute coronary syndrome. So this patient has got late phase of myocardial infarction, and late phase of myocardial infarction is diagnosed on the basis of ST segment elevation, in this case V1 to V4, T wave inversion, in this case V1 to V6, and Q waves, in this case V2 to V4. So we will see these changes in those leads which represent that part, and we are discussing in this module the anteroseptal or the anterior wall. It is actually anterior wall, not just the anteroseptal. Anterior wall myocardial infarction, because in this case it is the whole anterior wall. So we have seen these changes. So I think the diagnosis of anteroseptal STEMI or anterior wall STEMI is very sure. Which artery? Again, left anterior descending artery. So let's take this one. This patient also presented with chest pain. If you see this rhythm, right? This one, we don't see any problem with the rate or rhythm. And now we scan limb leads 1, 2, 3. In even the first limb lead 1, you see some ST segment elevation. Please note down that in limb leads, ST segment elevation is usually not that pronounced as you see in precordiales, because precordial leads, they record current of injury from very closer distance. They are just placed over heart, and ST segment elevation is usually very, very significant. In limb leads, ST segment elevation would be there, but since current is recorded from a distance, the ST segment elevation would not be that marked. So you will have to be very careful in inspecting limb leads. So if you examine this limb lead 1, I think you would agree with me that there is ST segment elevation and T-wave inversion in 1. 2, 3, AVF, they do not show any problem because they represent the inferior wall. AVL again shows ST segment elevation and T-wave inversion. If you remember that picture which shows different leads representing different areas, limb lead 1 and AVL, they represent the lateral part, the higher part. In V1, V2, V3, no much change, but in V4, we see TV inversion with little bit of ST segment elevation. At least this ST segment is convex upward. It may not be elevated, but it is convex upward, and this would be considered as ST segment elevation. Here just TV inversion, here just TV inversion. So what do we see? We see ST segment elevation and TV inversion in limb lead 1 and AVL, and then V4 to V6. These are the leads which represent the lateral side of the myocardium, lateral side of the left ventricle. So what is the diagnosis? See, I have shown you the changes. If you have missed them, anterolateral STEMI. Anterolateral STEMI. Technically, anterolateral acute coronary syndrome, depending upon the history. If troponins are elevated, it would be labeled as myocardial infarction. If troponins are not yet done or not elevated, then it would be called acute coronary syndrome. So these are the changes: ST segment elevation, T wave inversion, but no pathological Q wave as yet, because this is acute. And which lead? Lead 1, AVL, and then V4 to V6. So these are the diagnostic criteria of lateral wall infarction. Now, which artery is affected? You remember which artery supplies the lateral side of the left ventricle? I'll show you the picture. This one, left circumflex, the branch of left main artery which goes laterally and then backward. This is the lateral side. So somewhere here, the left circumflex artery is affected. So from the distribution of ST segment elevation, you have made the diagnosis of lateral wall infarction, and you have identified the culprit artery also as left circumflex. So this was all for today. We have discussed anterior wall infarction, acute phase, relatively less acute phase, and we have also discussed the lateral wall infarction. This completes this module. We are going to continue with ischemic heart diseases. We will cover the inferior wall infarction, the posterior wall infarction, and STEMI and ischemia. Please bear with me, and this has been Professor Azizur Rahman from Medurstand. Please join me again, and this channel is free, and you can watch videos, you can download them, and you can share with your friends. And I really look forward to see you in my next one. Thank you.